I'm very proud to present to you today Dr. Graham Forward, who is a consultant orthopedic surgeon with expertise in hip replacement and knee replacement, specifically robotic assisted knee replacements. He is also the founder and CEO of Australian Doctors for Africa, which is a nonprofit organization that is based in Australia doing different capacity building projects in Africa and Asia. He has received many awards and recognitions for his work through ADFA Australian Doctors for Africa, including recognition received by the Order of Australia AM, the John Curtin Medal, the GM Bedrock Oration of the AOA, Australian Orthopedic Association, Australia Day Citizen of the Year, nomination for the Australian of the Year for Western Australia, and of course, an award from the Ethiopian Society of Orthopedics and Traumatology for his contributions to the country's orthopedic development, just to mention a few. So I'm just so excited here. Dr. Graham, welcome to the Everyday Leader.
Hello, and hello, Ananya, and good morning from Australia.
Good morning to you. It's so kind of you to actually join us this early in the morning. So let's dive right into it. How do you define the phrase everyday leader from your orthopedic background or the work you do through your nonprofit? How do you define the everyday leader?
Well, you've started with a question that I have no idea how to answer. So good start.
Great.
Well, but everyday leadership, I think, in my mind, it involves the expression of leadership in not only every day, but in everything that you do. So maybe everyday leadership is one's daily life, because it's interesting that the very phrase leadership implies followership. And sometimes in everyday life, an everyday leader needs actually to fulfill the role of follower for some time. So being a good leader also implies being a good follower at other times. Uh, this is a very hard question, Dr. Ananya, that you've asked me to start off with. What do you think an everyday leader means?
Yeah, I love that. The fact that you mentioned one of the most important points that is not usually talked about is to be a good leader, you need to be a good follower, right? Because you have to understand the both mindsets, the mindset of being a leader and the mindset of being a follower, because that way you can empathize and understand the maybe the challenges or the perspectives of the people you lead, right? So that's a very important point, and I don't think it's mentioned enough, but it's quite crucial to becoming a, not just a leader because you're in a certain position, but also the persona of being a good leader. So I'm so glad you mentioned that. I think, I mean, being an everyday leader, it's in the phrase, right? It's an everyday practice. It's not a one-time
Mm.
thing. It's not a cape you put on and you take off. When you're a leader everywhere and anywhere and at any time. So it's kind of a character. It's an integrated character within a person's being, more than just something you turn on and off. Like let's say you're a surgeon in an OR. Like when you go home, you're not a surgeon anymore, or at least I hope not. That would be very unethical. So, like it is something you do in a specific setup, but leadership is different. It is in every circumstance that you practice being a leader. So that's how I see it. But I love the fact that you mentioned the following, the
Yeah,
follower.
And I think that's what I was coming at as well. There are certain times, even in the OR, where the surgeon doesn't actually continue with the role of leadership. There may be somewhat other expertise in that particular room at that particular time that requires handing over the leadership or handing over some of the parts of leadership to somebody with more expertise or more knowledge or more skills. And so an everyday leader is able to step aside from some of the leadership roles at some of the time.
Mm, yeah, wonderful. So,
Yeah.
it's usually, we usually see villains on movies and their origin stories, right? But here we don't have villains on the Everyday Leader podcast. We have heroes and sheroes, and people want to know the origin story. So tell us about Dr. Graham, where it started out and how it got to where you are right now.
Okay, well, I will, but stop me halfway through and it gets a bit tedious. So I'm a West Australian boy, born in Perth, the most isolated city in the world. To get from Perth to another major city, it's either 4.5 hours flying to the eastern capitals of Australia or 4.5 hours flying to Jakarta or Singapore in Asia. So, by definition, Perth is one of the most isolated cities in one of the most isolated countries.
Mm.
And so that's where I come from. Uh, when I left school with high marks because school is easy, uh, I took the line of least resistance and went to the university to study a commerce degree, junior business. I was the first person in my family ever to graduate from school. I was therefore the first person in my family ever to go to university. And we don't have a medical background in my family. So I took the line of least resistance, made as an 18-year-old, made a non-decision and went to university. And I had a good idea. I started a management consulting business, and it was very successful pretty rapidly. And so I have a very strong moment in my life. We were driving from the eastern states to Australia across the Nullarbor Plain. Nullarbor means no trees, and there's a section that goes for over 250 kilometres straight. And we were driving on this section in the evening, and I thought to myself, look at my life ahead. I'm age 25. If I keep going on this pathway, this is my life ahead of me. And so at that very time, I made the first active decision of my life. I made lots of other decisions, but they were passive decisions, and decided that I had always wanted to be a doctor. And I went back to medical school, and I started in medical school when I was age 25. And at that time, I worked out that I wanted to be an orthopedic surgeon. And so my medical and orthopedic career was uh, really simple once I made that key active decision. And so then I did the next steps. But very intriguing for me that I can still remember strongly that evening on the Nullarbor Plain with my life and the road stretching ahead of me. And I made an active decision that day.
Wow, I love that. Yeah, in a way, I think,
Yeah.
I don't know if you were you driving by yourself?
No, someone was with me. Yeah.
That's very interesting because I would, you might have this life altering decision making clarity moments usually when you're by yourself, but nature has a way of making your brain focus, like your consciousness focus in a way, um, in making decisions like that. A lot of people, I've heard that have experienced such things, right? They go hike a mountain or whatever, and then that the grandness of nature and everything just helps them, look into their life with through a different lens and things like that. So it's very interesting, that that clarity came to you in the least expected places. But well, obviously me and so many people who have known you, and worked with you are actually glad that clarity came at that moment.
Yeah.
So that's great. So it's interesting because you mentioned,
Well,
Go ahead.
Well, it wasn't the natural environment, but why I started off to tell you about the isolation of Perth is that very often for long parts of our lives, we don't actually make any active decisions. It's very we go along with the flow. We respond to our environment. We respond to our classmates and what opportunities are offered to us. And it's not very often in our lives that we actually make serious active decisions. And that was one of the few times in my life when I have.
Mm. So, did you do all your studies in Australia, or what happened after that?
Well, yes, then I studied medical school and orthopedics in Australia. And then, as we all do at the end of our orthopedic training, I went overseas for my fellowships. And by that time, I had a family. By the way, our children came at always at very tense and critical moments in my medical career. In Australia, we have severe exams in second year, fourth year, and sixth year medical school, and we had a baby each of those years. And then our next is our orthopedic fellowship year when we're after 4 years when we graduate, and that's a very severe exit exam, and we had another baby then. So babies and exams for us go together. So at the end of my training, then we had 4 kids and we went off to do our fellowships. I went to Birmingham and Nottingham in the UK, to Bern in Switzerland, and to San Diego in the US. Uh, like all fellowships, that was the most wonderful experience for a family and for professional development. And this is why I can see the need and the demand, especially in Ethiopia, for trained orthopedic surgeons to do fellowships overseas, partly for the cultural experience and partly for the professional development. So we were away for 2.5 years doing fellowships at that time.
Wow. Okay. Well, that's very interesting, and you're right. There is there's a perk to doing your fellowship abroad, and the cultural exposure, not just the cultural exposure, but also the exposure to a whole different health system on its own. It's very eye opening, and quite an important exposure for the surgeon. Um,
Yeah,
so let's come back to what you're really known for. Across the ocean in Africa, a lot of us know you through Australian Doctors for Africa. So could you tell us how ADFA came about, how it has developed over the past, I think, 20 years? You just celebrated 20 years, I believe, this year, right?
yeah.
Yeah.
So there's two streams. There's two streams to that. For one, right from medical school days, I never went on a holiday. We never went anywhere 5 star. We would go to places, and I would take my orthopedic toolbox and show up at hospitals and have a look at the emergency department and see how we could help. And so that was the first. I think I was a pioneer of medical tourism. That was our holidays, and from there, we always became engaged with hospitals in Madagascar and in Ethiopia. And then on Boxing Day in 2004, there was a massive tsunami which swept across the Indian Ocean. It wiped out large parts of Banda Aceh and Sri Lanka, and Australians rallied because we've got very close connections with those two countries. Uh, there was a big effort to help the Boxing Day tsunami recovery. And some Somali people rang up. They actually rang my wife and said, "We know that Graham goes to Ethiopia. Did you know that the tsunami continued across and damaged parts of the Horn of Africa?" So I put a team together of emergency physicians and anaesthetists and nurses, and we went to Bosaso in Somaliland. And before we went, I went on the radio, and a lot of money came in. So I needed to have a bank account, a name, and account for that money about what we spent. So on the spot, I dreamed up Australian Doctors for Africa in 2005, and we accounted for all the money. it was a very successful trip, and the volunteers who came on that trip said they wanted to come again. So we had another cocktail party upon return, and we started going to Bosaso in Somaliland in 2005 with an organisation now called Australian Doctors for Africa, with a bank account and with an auditor. And so once we had that structure, it was relatively easy to continue to grow. So thanks to the Boxing Day tsunami of 2004.
Well, yeah, thanks, but no thanks, but yeah. um, yeah, what a
Exactly.
story. It's very inspiring. I know because you have done it and it's been so many years and you've done many amazing work. You and your team have done many amazing work since that day seems very maybe compared to what you've done over the years very small, but I love the fact that you saw a need. There was a need. People were calling out for help, and I'm not sure because 2004 was quite a while, like long time ago. Maybe I was in med school or something. So a lot of people might not have even heard the news, right? So it wasn't getting even a news coverage that you had to find out through the people you know. And but the fact that you still thought, you know what, even though it's across the sea, whatever, across the ocean, I'll just do my best, try to do my best, and you got your colleagues together and raised funds, like you said, just good people who have probably never been to Africa to begin with, just extending helping hands. So that's such an inspirational story and just goes to show you that humanity does not depend on location or whatever else is currently taking center point in a lot of things. um, so during this time, during the past 20 years, because ADFA was started in 2005 officially, till now, what core leadership philosophy underpins the work you do? Uh, Whether it's in the ADFA kind of work or as a surgeon.
Yeah, so that's also, you're good at asking tricky questions. That's a difficult one. But the leadership implies knowing where you're going. And I do think that it's a leader's obligation, a leader's role is to work out the destination. And once that's done, uh, that would be called the vision in leadership terms. But in geography, it's just knowing where you're going. And if you know where you're going and you have the vision, then a leader is able to collect the people who are on that journey and bring together all the disparate parts that are needed to achieve and arrive at that destination. So I think the fundamental part of leadership for me is having a vision or knowing where you're going. And in Australian Doctors for Africa's circumstance, that was really simple. It was to help our cousins across the Indian Ocean in Africa to do better with their healthcare, especially in orthopedics and traumatology. So uh, that's not a particularly precise roadmap, but once you have that idea that you're going to train and equip surgeons in the poor parts to help the poor people, not necessarily in the poor countries, but to help the poor people, then uh, you've started on your journey, and all the other details more or less fall into place. So I do think that the fundamental part of leadership for Australian Doctors for Africa has been to have a vision and a simple phrase like train and equip surgeons. It really helps with that vision.
Yeah, interesting. Knowing your destination, that's powerful actually. It sounds simple, sounds kind of cliche, but the difference between those who have succeeded in you know doing that and the ones who just know the concept but never actually applied it, it's evident in the outcome. So It's very important. It could, like you said,
Well,
it could be as simple as there are people who have need. I have something I can offer that they might need. So let's go and do it. It can be as simple as that, like you mentioned.
yeah, and we were talking before about the importance of followership because followership is as much of a skill as leadership is a skill. But if you think about that, knowing the destination, and okay, we're going to go on a voyage, we're going to get on the bus, and we're going to arrive at a destination. Then the only people who get on that bus are people who want to go to that destination. So they are the followers. And if a leader is able to clarify the destination and clarify the objectives and what they're trying to achieve, then on board that bus, you've only got dedicated followers, people who don't want to go there, don't get on the bus. And so once you've got that vision, then it's pretty easy for people to decide if they're going to get on the bus or not. In other words, if they're going to be followers of this leader or not. So I think having a vision is, and it can't be an artificial vision. It's got to
Mm,
be just, it's got to be the whole thing.
yeah,
Does that make sense to you?
it makes so much sense. Yeah, I think,
Yeah.
especially when it comes to helping others, um, artificial visions wouldn't go a long way. They might get things started, but it will not have a lasting impact. Which I sometimes reflect on. We have a lot of other nonprofit organizations involved in different projects, let's say in Ethiopia, for example. But when you really see the impact of those projects, it's questionable, right? On paper, it looks good, but on ground, what has been done is there's really not much of an evidence there. So, like you said, when something is just artificial, it's just on paper, it's just, but when it really comes from the heart and the pure desire to just help other human beings with whatever you happen to have. It could be, the people who contributed with money. They were not doctors. They had some money that they could share a little bit of extra, and that's what they did. Or maybe it's not even extra, it's just maybe the kindness in their heart that made them do those things. So, and people who don't have the money but who got the skills, contributed with their skills. So it's really, really, like you said, it's something that comes out of the heart, not something that just looks good on paper or to hear about. So yeah, I usually reflect on that when it comes to a lot of projects, that Australian Doctors for Africa has done. Um, I also wonder if has your background of business, has it shaped the way you lead in healthcare? Has it influenced it in any way?
Well, I I don't think so. I think uh, my parents' background, we were not a rich family, and money and spending money from my parents was we were careful with money, and so now in our family life we're still careful with money, and in our organisation, Australian Doctors for Africa spends our donors' money as though it was my own. So yes, we're careful. We have limited funds, and we have to allocate them in the same as every family has limited funds. So, but I'm not sure that's my commerce background because I was only in business for a few years. I think that's more my uh, frugal parental background more than anything. But I do believe, despite the wealth and materialism of our whole world, that it's our obligation to be careful with our resources and careful with our funds and careful with our environmental resources, especially.
Yeah, very true, very true. Because sometimes it just all ties back together for me when I hear you talk about it. Because if you have, um, first of all, an organic desire to just help others, and then you have a destination, an end that you're trying to achieve, and then you don't need to be pumping so much resources to do it, because what you got those two things that are most important for impact already in place. The money is just a very simple means to that end, right? But you see a lot of projects that just pour a lot of money, and
Yeah,
impact wise you really don't see much of an impact, because it's either that organic desire to help was not there. Maybe it was just a project to tick boxes. Maybe, um, you want to, pump up projects before the fiscal year, whatever, the budget and everything related, or the end goal is not, it's missing the target completely. So no matter how much money you pour into it, it's not going to have the results that you would want. So yeah, it all
yeah.
ties together. Yeah.
Well, that's true. And when people ask me, I frequently say we're a high energy organisation and a high relationship organisation. We're not a high financial organisation. The strength of Australian Doctors for Africa is its energy and its commitment, rather than its finances. But if I could just follow that one more, we've got a charter. It's actually a handwritten document that a couple of us wrote shortly after the organisation was founded. And so we don't regard ourselves as an aid organisation. Only partly do we regard ourselves as a development organisation. We're really a partnership organisation. The first line of our charter is Australian Doctors for Africa goes only where we are invited.
Mm.
Uh, that means right from the very start, we're a guest, uh, and the project has been initiated by other people. And then the second line is we're there not to take over, but to give a hand. And that's a pretty Australian expression. We're there to give a hand. That means it's your problem, it's your country, it's your orthopedic and traumatology service. And if you ask us, and we can, we'll fit in and try and help. Uh, they're two very empowering statements because it means that the responsibility for development of a service rests with the local people, as it should. And if we do help take one step, it's usual that the local people then take the next three steps. And when we go back in 2 or 3 years' time, it's so advanced that we look to see how we can help take the next step. So those two simple phrases, go anywhere invited and give a hand not to take over, that makes us slightly different from other aid or development organisations. Have you noticed that?
Oh yeah, oh yeah, for sure. And I think it works. It works perfectly well because, again, it comes back to how some projects miss their target because they are actually coming to the people saying, you know what, you need this. And it's like, but do we? And sometimes,
Yeah,
I don't like using that term, but beggars can't be choosers sometimes. So you just say, okay, maybe if we do this project with them, then they might help us with the other stuff we actually need, right? So
yeah.
it's a very complex environment, to be honest. And but yeah, I love the approach that you guys use, which is go where you're invited. Yeah.
Mm.
So you just touched on that a little bit, but it's training of manpower followed by equipping of institutions, so that it could be independent of you know continued support has been the signature move of ADFA, whether it's in Ethiopia or Somaliland or Madagascar or anywhere else that the organization has been involved. Why was this approach chosen? Was this how it started out from the beginning, or was it something that you had to implement from experiences, maybe failed experiences? um, and how effective has it been for ADFA?
Oh, well, it just started out from the heart, really, because like you, I'd seen so many uh, not failed projects, but wasted projects, wasted efforts, where, and one of the common things was a mismatch of expectations. One party had been promised or expected uh, an outcome, and another party had an entirely different expectation because they weren't a partnership. They weren't working together. So right from the start, we've tried to build personal relationships uh, with good people, and then empower those good people or good hospitals or good organisations so that they could do more. And so, right from the start, if you're working from the heart and you have a good roadmap, then you can manage expectations much better. And we've had a few mistakes where we've expectations haven't been fulfilled, despite delivering a perfectly good toilet block or a very good water supply. If you had not had that partnership and you weren't taking the steps together, then it's pretty easy to have a mismatch of expectations. And managing expectations in this world is pretty important.
Yeah, that's very true. And you mentioned the toilet block or clean water supply, because sometimes when you go to certain places, um, it's easy to think, okay, the world is advancing in technology, so let's give them smart glasses or something
Yeah,
very advanced. But the real issue that institution has could just be simply water supply, or availability of oxygen for theater, or something very simple, and that can be solved very easily. So yeah, so it's very important, and like you said, it's the relationship. So if you have close relationship with the people on the ground who are actually doing the work, it gives you kind of an advantage to understand the problem more in depth, as compared to just being an outsider and talking to maybe the CEO of a hospital or the health minister of a country, right? Because yeah, those people have like a general information, but it's when you go down to the people who are actually doing the day-to-day work, that's where you actually see um, where you can influence the most.
yeah, and for us, that's where the big wins are. So, just for people who might be listening, Dr. Ananya has been with me. In the morning, we met with the Federal Minister of Public Health, and in the afternoon, we went to inspect the toilet block and the change rooms at the Black Lion Hospital. And uh, for us, that's where the gold is. If you can provide clean, sterile operating rooms, then that's what we're interested in. And the only way to do that is to actually go there and see where the water supply comes from and see where the filtration system and look at the temperature of the autoclaves. And so it's not uncommon to have highly skilled orthopedic surgeons in their overalls looking under to see where the water supply comes from. And I really like that about our organisation.
Yeah, yeah, I agree. Are there any projects that have been learning opportunities for you, whether it's for the good or for bad, whatever, but it has been a learning opportunity?
Uh, so I think most of them are embedded sort of opportunities. What I've learned is that everybody has power, and I'm very interested in the power dynamics because that's how you achieve things. And no matter who you meet in a hospital, in a health environment, or even just in a travel environment, everybody has some power. And the golden rule of power is that those who with the least power use it the most. And but nonetheless, everybody who you come across, from the porter to the receptionist to the minister of health, has some power. And working out what power they have and their willingness to use that power in your favor, once they're on the bus, it's likely that they will employ what power they have to help you achieve your destination. But working out what power they have is and how they can use it together, that's been an embedded learning from pretty much all our activities. I'm not sure if that was an answer to your question, but do you know what I mean about how everybody has some power?
Oh yeah, 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 100%. And actually, that's I think where a lot of people make the mistake, by undermining others. But like you said, everybody has a certain level of power and influence.
Mm,
So you just have to understand that, and honestly, you have to also respect that boundary of power, and um, try to come up with solutions where everybody feels heard and understood, and like kind of everybody stands to benefit as part of a system, right? So
yeah.
yeah.
And so we're spending an awful lot of time talking about toilet blocks here, but in Gonda, the orthopedic hospital ward was not in very good shape with unhygienic toilets. We assembled a partnership. We had hospital engineers, we had donors, we had an international group. We had everything in place, and we hadn't quite forgotten, but we hadn't got around talking to the chief nurse who looked after the orthopedic ward and therefore had access to the toilets. And he had the key to open and close the doors. And fortunately, before it was too late, we engaged with that particular person, a very wholehearted and hardworking man who was the chief nurse. But we went close there. If we'd continued on our pathway of dogmatically mm, implementing something, that wouldn't have been a good success. Instead, he got on the bus at a pretty early stage and he brought his key with him. He brought his little bit of power, and it turned into a very successful project. But you can make a mistake by ignoring one person who's got one key to one door, and the whole project can fall apart if you haven't had respect for those power dynamics. So I'm pretty tuned in to working out the power dynamics in advance.
Yeah, which I think is actually the most effective approach,
Mm,
to have a successful outcome in projects. Um, well, how about, I know Australian Doctors for Africa, and you and your members, your team members, have always advocated for um, women empowerment, female empowerment, and things like that. And you've given a couple of scholarships for female surgeons, female orthopedic surgeons, just to boost that number. Because it's not just an African issue, but it's a global issue that there is a very small number of female orthopedic surgeons compared to male orthopedic surgeons, whether it's in the US or Australia or really anywhere. So what kind of work ADFA has done in that, and how what do you see for the future of that? What do you see?
mm. So that's partly about leadership as well, isn't it? All our teams during this year, we would have sent away uh, either 22 or 24 teams of groups of 6 or 8 people. And they're all tuned into the idea of the importance of women in the workforce, in the urology and gastroenterology and orthopedic workforce. And so I hope that some of our team's leadership, just by showing up and having respect for the women in the team, a lot of our team leaders are women, that those sort of role models might just automatically and osmotically transfer to locals. That they see a urology team led by Dr. Lydia, and they think, well, how come she's a leader of an Australian Doctors for Africa team? So I hope that one way is by example, uh, and the second way is just by small ways. We have a small bursary. We pay for some medical students at Edna Aden University in Somaliland. Uh, the Female Orthopedic Empowerment Program in the Horn of Africa is a potentially very potent way of encouraging junior doctors to embark on an orthopedic career. And so we're trying to think, always trying to think of ways. We need more women in our lives as orthopedic surgeons. And in Australia, we've given lots of thought about what the barriers are. And Australia, we're very open to women joining the orthopedic. Well, I was just about to make a classic error and say joining the orthopedic fraternity. Well, there you go. That's how inbred these prejudices are, because it's a sorority as well as a fraternity. But uh, come on, girls, get on board. We need you in orthopedics.
Yeah, it's very true. And it's a topic for another day, but there are studies coming out showing that, at least in the US, that female doctors, physicians have higher rate of depression, um, and suicide and death and things like that compared to their male counterparts. So, even if women are being encouraged to go into the system, it really kind of makes you want to stop and ask, is the system actually ready? You know, because those those results don't come for no reason. There is something happening in the system that is causing dissatisfaction, and job dissatisfaction for female physicians. And I guess the more specialized you go, the greater the challenge. And the more male dominated field it is. So it's very important to actually do that grassroots work, and like you mentioned earlier, um, just watching people similar to you, watching other women doing successful things, or things that defy cultural norms, which are actually still culturally highly influenced in some parts of the world. And that mentorship part, that not just, oh yeah, you can be a urologist or an orthopedic surgeon or a vascular surgeon or something, not just that, but how it is to explore that environment as a woman. The unspoken part, the silent part that people suffer behind closed doors, the challenges and everything, and how to go through those things. So
Yes.
yeah, I think it's, go ahead.
Well, just to go further about that, it's a global phenomenon. In Australia, we've only got 7% of our orthopedic workforce are women. It's also a cultural phenomenon. In Somaliland, women still wear a head cover and sometimes a burqa. But in January, two orthopedic surgeons, female, are going back to Hargeisa Group Hospital. They will then represent uh, two ninths, whatever, 22% of the workforce in Somaliland. That far exceeds the percentage of women in the workforce in Ethiopia or in Australia or in the US. And here's a country that's most culturally restrictive of women, and yet they and we have been able to achieve a 22% workforce. So uh, you explain all that to me. Yeah.
Yeah, well, it's math, but you already know the answer to this, so
Yeah. Yeah.
it's proportions. Yeah, but I'm just saying, like, it's very important, and any sort of work and support towards encouraging more women into a workforce. I mean, like, if that's what they want, to be honest, there's nothing wrong with wanting other things out of life as well. But if that's what they want, at least they, like, organizations and even individuals have to encourage in their own capacity to create that environment for them.
Yep.
Um, so in the past week, we had a poll. I had a poll on my LinkedIn page, and it was focused on possible solutions to changing brain drain to brain gain. And I know you and I have had many conversations around this. So, from your experience, what has been the most effective approach when it comes to retention?
Well, the most effective approach, as in everything, is the truth. And uh, very easy in a country to look on the internet and be seduced by the falsehood of what's available in materialistic terms. But the truth is that when an Ethiopian goes to Washington, they exchange some materialism, perhaps some material gain, for a cultural and a professional loss. So uh, I'm very, and I've had lots of conversations with lots of people, not talking them out of going to the US or coming to Australia, but just explaining the truth of the situation that from being a doctor in an African country, it's with culture and family and opportunities in that African country. It's not always the truth that it's going to be better on the other side of the ocean. So it's not a very structured answer to your question, but the grass is not always greener on the other side, and the sacrifices uh, are great. Plus, uh, I see the opportunities in Madagascar and Zimbabwe and Ethiopia as tremendous. In some respects, I think Australians, if they're looking for an opportunity in the orthopedic world, uh, go to Somaliland, go to Ethiopia. So it's interesting how your perceptions affect your decisions, and I think the truth is the only way of making a good decision. So it's a bit of a long way around your answer, and that won't change the brain drain. But there's a lot to be said for staying home and building your own society.
Yeah. Has there been any approach that Australian Doctors for Africa has taken, because you're heavily invested in training, and you have so many young people being trained every year, in the hopes that they are trained abroad, obviously, and in the hopes that they would go back to their home country, back to their mother institution, and serve the population that it was meant for. So, has what approach have you used to retain those skilled professionals, despite the environment not necessarily being conducive?
Okay, so yeah, at two levels. One, so when we're involved in the orthopedic training program in Ethiopia, training high quality Habesha orthopedic surgeons, and I don't mind if they stay in the government hospital or they start their own private practice in Ethiopia or if they come to Australia. So I don't regard that as a loss because it's a whole world. And if you've trained somebody, they'll find a position at some place in the world. So I'm not particularly concerned about the brain drain at that level. Because, and as a matter of fact, very few of the people that we've been involved with training in Africa have actually left their home countries. Once they have the skills, they very often see the opportunity and they decide actively to stay and exploit the opportunities with their new skills. And then there's another cynical part of us, Ananya. In general, I prefer uh, surgeons to be trained in India for two reasons. Because India is superb for orthopedics and traumatology. Their skill level and their caseload is extremely high. And secondly, in general, people don't like the food in Ethiopia, so they want to go home. So we're very much in favour of our fellowships, that is, the overseas trainees, uh, India and Egypt, where the training is superb and there's not much temptation for them to stay there. So that's a bit cynical, isn't it?
I mean, it is what
Yeah.
it is.
Okay.
But yeah, I mean, it works, that approach. And I love the fact that you mentioned it doesn't matter. Like, once these people are trained, wherever they go, they're serving somebody in need, whether it's in their home country or somewhere else. Yes. But I mean, overall, you kind of have to, you kind like proportions that we were talking about, right? Population to physician ratio or healthcare professional ratio. Most Western countries have a large number, and most African countries are haven't even met the WHO standards for that. So I know that for sure about Ethiopia. So it is really a loss, if you look at it as like a whole, as a system. But um, for that individual, you're right. Everywhere they go, they're still serving somebody in need at the end of the day. So
That's true. And then the second part, which is a much more positive thing than that rather cynical comment about Indian fellowships, our motto now is train and equip. And so it's a responsibility on Australian Doctors for Africa, once we're involved with training people, is to provide them with the equipment and the resources so that they can then implement their skills at home. So that equip part, that's starting to become overwhelming because we've got such a lot of new orthopedic surgeons, but it is a responsibility. If you want to stop people from going to Malawi or Rwanda, or uh, to the US, then you've got to provide them with the equipment so they can implement their newfound skills. So that's a responsibility that we take pretty seriously, and we're not quite able to keep up. But that's why I was just with the Minister of Health in Ethiopia saying you've got to provide better facilities, better resources, and better equipment for these 160 new surgeons who are coming on stream every year.
yeah, I think everybody has to play their role. Like you said, maybe as a donor, somebody from, who's external, you really can't do much about influencing those people, trained people, to stay per se. But the institutions might have some say, like you said, providing equipment. The Ministry of Health have a say, making import of equipment easier, or financing equipment, right? There's a lot of parties involved, and if everybody's doing what's expected of them towards that same goal that we talked about earlier, that same um, uh, destination, then retention is not going to be that hard, and we're bound to succeed with our skilled manpower. um,
Yeah, so let me use just Somaliland as a concrete example, because when we first started, there were no trained orthopedic surgeons in Hargeisa or Somaliland. 5 million people, no trained orthopedic surgeons. Now we've got a department of nine. We will in January, fully qualified, trained, skilled orthopedic surgeons. And so the next step is to provide them with so we're going to renovate 3 new operating rooms and equip them so that those surgeons have got an incentive to stay in Hargeisa or stay in Somaliland. Otherwise, who could blame them for wanting to go somewhere where there are adequate facilities and equipment so that they could use their skills? So part of the brain drain is to match the resources with the knowledge.
100% agree.
Yeah.
um, so you've been involved in Africa, like you mentioned, for 20 years now, on different scale, right, in different countries and regions. What has been your observation on progress of healthcare in Africa as a whole now versus 20 years back, and what key factors do you think have contributed to its progress, or you know deceleration, whichever it is is referred
Yeah.
to?
Well, look, tremendous progress. Uh, I know orthopedics and traumatology the best, and the difference between 20 years ago and now is a spectacular improvement. Not to say that it's perfect. One of the things that is happening, as is happening in all parts of the world, is bipolarity. There's a lot of people still being left behind. We have yet to access the poorest of the poor. Often, when technological advances and medical advances occur, it happens for a lot of people, but a lot of others don't uh, aren't beneficiaries. So I would say over the years, I've seen tremendous improvement. Uh, Things are very good in most of the places that we go to now, but there's still massive gaps where the poor people have, or they've missed the bus. And so, how to address that is a challenge for everybody. And it's a challenge that's recognized by the poor people and the young people. That's why we've got Gen Z riots in Madagascar at the moment, because so many people are not beneficiaries of the improvement that's happened in the healthcare system.
And that's an important observation, I would say, because um, it's a lot of progress has been made, but at the same alarming rate, there's also inequity still. Like just like you
Yeah,
said, there's just a huge gap, um, and it's not just. I mean, the economics of things obviously contribute to the healthcare inequity as well. It goes hand in hand, right? So yeah, when
yeah.
the hmm go ahead.
So our objective is to help the poor people, but to help the poor people, to get there, a lot of the beneficiaries are the rich people or the middle class. Nothing wrong with that whatsoever, but
Mm,
it's really hard to reach out into communities and find ways of helping the poor people.
yeah, I agree. That's something to really think about, and
Yeah,
it's something to think about for policymakers as well, policy, because a lot of things are, you know, if the policy does not have that map, uh, then there isn't really much you can do because resources will be allocated based on whatever is prioritized. So
exactly.
it will just expand that gap.
Yeah.
Um, so you have a unique position as you've been exposed to different healthcare systems, right? Whether it's during training, whether it's during your um, work as a surgeon, as part of your nonprofit. What do you think each system can learn from one another, or is it really a one-way thing, as it seems to be for so long? Like the uh, global south is learning from the global north kind of thing, or do you think it's a bilateral, a two-way um, thing?
Yeah. So, uh, so just a couple of things. The main one is what we were just talking about. In the US and Australia, physicians have lost a lot of interest in poor people. There's a bipolarity and a lack of interest in the people without access to good health care. Whereas let me talk about Ethiopia. In Ethiopia, physicians and doctors and hospitals still care about their poor people and might not actually be able to reach into their lives, but still have an orientation in that direction. And so, Australian health system could learn a lot from Ethiopia about how to not abandon the poor people. I'm not saying Ethiopia takes care of them perfectly, but they still consider them and care about them. And so that's uh, and then the second, I think it's a global observation. The second thing that's happening is a rise of respect for ignorance. Uh, uh, Orthopedics is still a very technologically research driven, knowledge based factually based profession, and we know a lot. But if you go on the internet, there's a lot of misinformation, falsehood, and ignorance, which is beautifully presented, wonderfully packaged, and very seductive. And it's one of the dangers in both our healthcare systems is that we're going to enter a dark ages where ignorance has more say than knowledge. So I'm hoping that, we're not a very research-based organization, but we have great respect for facts and knowledge. And out there in the world, there's a lot of disrespect for facts and knowledge. And that's more in the Western country. Well, it's more with people who have access to internet and social media. So I hope that you can do your bit, Ananya, to keep us respect for facts and respect for knowledge.
Yeah, I mean, that's actually a fantastic point, and it's something that I am now constantly worried about because historically, even if you look at scientific data, the source of scientific data has kind of been a certain group of population. Um, and there is this whole other group of population, which is actually the largest group, that is not scientifically represented. And now that, with technology advancement, not just social media, but in the age of AI, these are language learning models, right? They're learning from whatever data is available out there. So now they're learning from a biased data set. So what does that mean? In practical translation, what does it mean and how does it affect the healthcare system? Because before we even address that, it's being integrated immediately into the systems, the healthcare system, without much of an evaluation, right? So it worries me. I don't know. I don't know how you feel about it, but it worries me constantly.
Well, it worries me. It just reinforces my respect for those people who are primary generated content is king, and those people who are generating primary content, whether in a laboratory with a microscope or with an operating theatre counting cases, these people are so valuable and becoming more valuable. So uh, I'm developing much more respect for a fact because a fact is so much more important than an opinion in the medical world. And somehow we've got to make sure we hold facts and knowledge primarily in the whole world's health systems.
Yeah, that's a good point.
A depressing point.
In a way, but we also need to face the reality, and that's a reality. The earlier we face it and understand it, the better it is for us to come up with solutions before it goes any further.
Yeah.
So yeah, that's why it's important to have these discussions. So what do you envision for the future of healthcare, wherever it is? How important is it to see healthcare from the global perspective while strengthening the local system?
Well, the biggest, most spectacular breakthroughs in the last 10 years have been with data and multi-center trials. And so the global integration of knowledge and research is just the greatest opportunity. Look what's happened with immunotherapy and the treatment of the blood cancers and melanoma and lung cancer as a result of uh, integrating the research efforts of multi-centers and doing multi-center trials. So, and the importance of including African countries and African databases and African knowledge just can't be underestimated. So, whatever we can do to integrate that more diverse populations with more diverse research and then bring it all back together, this is just tremendously exciting. Not so much in orthopedics and traumatology because we're such concrete thinkers, but in the rest of the world, there's so many spectacular opportunities ahead of us. I'd like to try and think of some ways in which orthopedics and traumatology could participate as well.
Yeah, and I think if we learned anything from the pandemic, the most recent pandemic, is that we are very interdependent,
Yeah,
and unless and otherwise we think of things from the global perspective, um, there is no escaping the effect of failed healthcare system wherever you are. You can be miles away, but it is inevitably somehow going to affect you. So that's a good point. Well, thank you
yeah.
so much
Welcome.
for coming on to the Everyday Leader. Much appreciated. I appreciate you giving your time for this, and I hope to see ADFA doing more phenomenal work as it usually does, and help out people in need. So thank you so much.
Good. And from my side, thank you very much for your time and your dedication. And let's hope that the everyday leader works on propagating knowledge and facts, as I know you will. Nice to chat, Ananya.
Thank you.